the case that made me a believer. So this really was the case that really got me thinking very, very seriously about this platform, and I'm now incorporating this platform significantly in my practice. A patient with a T2N1M0 non-keratinizing squamous cancer of the tonsil, ipsilateral neck metastasis. He had a pretreatment TTMV, as you see, almost 2,000. Went to the operating room, had a transoral resection with an ipsilateral neck dissection. He did have a fair amount, which was a little surprising, of extranodal extension on his neck dissection, but we see that about 30% of patients who have an N1 or an N2 neck. Extranodal extension is, remains a little bit of a pathologic feature that, if you look for it really hard, you might find it more than you think you'd find it. But I think several authors have shown that you can see it in N1 and not insignificantly in an N2 neck. So he did have chemotherapy and radiation post-treatment, but post-surgery. But what was interesting is that his pre-adjuvant therapy TTMV only went down to 450. So he went from 2,000 to 450 a couple of weeks after surgery before he started his adjuvant therapy, despite what was a good operation, negative margins, negative nodes, but persistently positive. So we were very concerned about that. But absent any surgical findings that would lead us to go back to the operating room, and absent anything else and absent any distant metastatic disease on his pretreatment PET-CT, we elected at that point to proceed with chemotherapy and radiation in the adjuvant setting, and he went on to get cisplatin and radiation. So at the completion of his cisplatin and radiation, so 3 months after the completion of his adjuvant therapy, his TTMV went down to 10. So if I could have inserted something at that 10, I would have inserted a picture of me with my fingers crossed, hoping that that would either continue to decrease or move in a favorable direction. But it didn't. So 3 months after, within now his first year, so 3 months after the we got that TTMV of 10, so about 6 or 8 months after the completion of his adjuvant therapy, asymptomatic patient in routine follow-up, I got another TTMV, and it went from 10 to 150. So at that 150, we got additional imaging. So let's look at the PET-CTs now on the right side. That P1 is his original pre-treatment PET-CT scan. Standard right-sided T2N1 M0 P16 associated squamous cell cancer of the head and neck. The T2 PET-CT scan is his post-treatment 3-month PET-CT scan. So at his post-treatment 3-month PET-CT scan, we have nothing, and that corresponds to the TTMV of 10. So now here we are 8 months post-treatment, negative physical exam, no indication to order imaging. We get a TTMV that's now gone from 10 to 150. And that prompts the S1 PET-CT scan, which shows a contralateral neck metastasis. So we now have a contralateral neck metastasis correlating with a TTMV of 150, and he goes to have a neck dissection. And he has a contralateral modified neck dissection where we spare everything for what is essentially an N1 node, okay? And his TTMV goes from 150 to 0. So not just proof of principle, but significant change in therapy with this patient ordering the additional imaging and subjecting him to a much less toxic operation than he would have needed if we had allowed this neck node to proceed to develop a palpable neck node metastasis requiring a more significant surgical procedure. He could get by with basically a sort of an extended selective neck dissection, sparing everything, and then we're radiating that contralateral neck. Because it was not, we went back and looked at his pre-treatment or his radiotherapy plan, and we did not treat that neck. So now we're going to treat that contralateral neck. And we have a TTMV of 0. So this is what sold me.